Well, welcome everyone. I'm so glad that you're here for this webinar hosted by Dime. Today we'll be talking about the new tool that the Impact Group is launching called the Impact V1C Core Competencies. And I'm very excited about this. It's been in our hopper for quite some time now. And we sat down in October to start drafting this, and I'm very excited to talk to you about it today. So a couple points of housekeeping. This session is being recorded, which is great because if you have to pop off or if you really love it and want to share it with your team later, we will be sending you out a link to the recording and the slides. I will do my best to allow time at the end of the session for Q&A, but we also could get to your questions live during the meeting. Two ways to do this. You can raise your hand and we can ask to unmute you. You can ask your question live, or you can type your question into the Q&A box. So you'll see the Q&A box down at the bottom. And again, we'll post all these things, and we really do invite you to share this broadly amongst your teams and spend some time after the webinar checking out the materials. We are asking that people do not transcribe the webinar. It's a bit disruptive, and you can certainly, again, download these slides and video later. So again, welcome everybody. This webinar is hosted by the Digital Medicine Society. If you're not familiar with Dime, we are a global nonprofit dedicated to advancing ethical, effective, equitable, and safe use of digital medicine to redefine healthcare and improve lives. And out of that lofty mission, you can imagine that the best way to do this is to really anchor firmly at the intersection of healthcare and technology. Make sure that we have the right voices, both from the tech community as well as patients, providers, and health systems, payers, et cetera, at the table to make sure what we're building does actually accomplish what we need it to. So I'm very excited to be a member, to work for Dime. And the specific role that I have, name is Lynette Demers, I lead the Impact Initiative. And Impact Initiative, the group that is responsible for this body of work, is a pre-competitive consortium, the membership-based initiative that is dedicated to advancing access to high-quality virtual first care. So I'll give you a moment to look at the logos on this slide, really give you a sense for who comes to the table when we work on these problems together. And you can see that I could have sorted them, they're in alphabetical order. We're really looking at members from the sort of the buy side of the table, from the builder side of the table. We're looking at, we've got funders and investors, as well as the infrastructure and enabling technology folks. So we really have all the right people at the table. Who's not on this slide are our incredible group of patient experts who are, I would say, are loud and very significant voice at the table. Excited to always have them there. So this group sat down 2 years ago now, 2021, to work on the problems that we could work on together as a group more effectively than as individual components of the ecosystem. And the first thing that we did is define what is virtual first care. And back in 2021, this idea was still coalescing as something very, very different from the video-based telemedicine that we were all becoming rapidly forced into and familiar with. Very different from just another tool in the toolbox, but really the opportunity to redesign healthcare around the needs of the patient, intentionally selecting the site of care. So not just virtual, not just in person, but really thinking about how can we use our digital technologies and modes of communication to meet people where they need to be met, based on the clinical situation, based on their preferences, to initiate care anytime. So really moving away from the visit-based system to when patients need care, again, using the latest technologies that we have. And again, the idea that healthcare is so fragmented, and we tend to develop these great solutions that are point solutions to a specific problem without thinking about the whole. We really emphasize that virtual first care has to be a complete solution that really contemplates the journey to health by bringing all of the pieces together under one roof, or doing the hard work of connecting the pieces together. And again, the point I always want to emphasize, and so relevant to this discussion today, is this is healthcare. These are healthcare providers that are subject to all of the same rules and legal obligations to patients that other healthcare providers, traditional healthcare providers, are subject to. Okay, so with that, very, very exciting time in 2021. Lots of new companies. We're very excited about this model. Investment dollars are flowing. And when we sat down last year in 2022 to think about what we needed to do is define both what is virtual first care, but what does it look like when it's working very, very well? And with the explosion of new companies entering the market, how do we go about defining what really great virtual first care looks like? And again, this was 2022. So again, still a very exciting time for the innovators. And when we sat down to do this, we started to chart out what's in the ecosystem. And again, if I map all of the 250 companies, if I filter them by the year that they were formed, many were formed in 2021. If I filter it by what types of services they're offering, they are offering all the different components of virtual first care that we defined. But now here we are in 2023, very different market. We're starting to, I think the best expression is that we're starting to see both the buyers and the builders starting to look at the fine print. So how well does the solution fit the needs that employers have? How well are these companies protecting information, et cetera? So this group sitting down to really define what good looks like in virtual first care had, I think we had the elephant parable, the four wise men and the elephant. I don't know if anyone sort of remembers that parable, sort of examining with blindfolds on. Everybody comes to the problem with their own perspective and priorities, right? If you are a patient, you want one thing. If you're a health plan, you see the other. And the beauty of the impact group, as I go on and on about how great this group is that we have all the right people at the table to collectively agree on what good looks like. And what we're starting to learn and seeing, and you guys can also see the headlines, but growth at any cost, growth that compromises potentially patient-sensitive information with ad retargeting. That is not going to be good in the future. We've got an erosion of trust there. We've got growth or bringing a product to market that is scientifically not ready yet. Again, those companies are not going to be sustainable, regardless of how exciting they were when they were formed. And Jen said it this morning to me. She said, so really what you're saying is you have to be able to walk and chew gum. It's not good enough to just be great at one thing anymore. We're really looking at selecting out the providers, the virtual first care solutions that can be good at all things. So given that, how does this group come together and define sort of the foundational elements of excellence in virtual first care? I'd like to introduce my panelists, and I will stop talking and we can dive into the content. But really briefly, we have Chris Kaya, who's the lead director from Aetna Virtual First Care, can bring the perspective of payer. Shelley Lanning, co-founder and CEO of a women's health virtual first care company, Visana Health. Shelley also brings to the table a perspective as an investor in her former life. Elizabeth Zeck, who's a principal at the Center for Health Innovation at Mercer. Mercer, as everyone knows, represents the self-insured employer market. And Carrie Nelson, our physician on the team here, who's the Chief Medical Officer at Amwell Medical Group. So happy that you are all here to talk with us. And we have a bit of a microcosm of when we were working on this project together, bringing people around the table. So with that, I'm going to unshare my screen here so we can have a conversation. And I'd like to turn first to talk with Chris about this whole idea of defining what good looks like. What are the elements of great virtual first care? Came, I think, first and foremost from your group at Aetna, a conversation we had that was like, whoa, we're getting so many companies come across the table. How do we evaluate them consistently in such a way that doesn't, crush the startup, but really gives you guys an efficient way to come up with sort of level setting. So dive in, tell me like what problem are we really solving here from your perspective?
Yeah, so that's spot on, right? You being who we are, and what we represent in the ecosystem. Obviously, there's a lot of partners that want to work with us, and that's fantastic. We want to work with them as well. The problem comes in though, because we are so large, there's no one channel into our organization, right? And depending on which channel you choose or are fortunate to make it in through, they have very different lenses. Our clinical teams look at things obviously from a very clinical lens. Our product teams look at things very much from an economics lens. Our provider teams look at it very much from a patient care lens. And so depending on where a journey starts within the company, there's a very different lens used to evaluate these opportunities, and there's no common language when we then bring those opportunities to the other parts of the organization to gain buy-in, to gain insight, and to really move forward with an opportunity. And so I think this tool does a great job of creating that common foundation for diligence and creating that shared language for our organization to have a conversation around the opportunities and the partners that we're considering.
I love that. That was one of our, I think one of our key goals is to, again, create a common language both for on the buyer side so that you would have a common tool, but also on the provider side. And Elizabeth, I know coming from employers bringing, again, a whole different perspective of needs, but knowing that they may be focused on one area, and the opportunity for us is to help them get the right tools for their patients and make sure that they're valued. So I know you've done some recent research within Mercer on what the employees want and how employers are trying to sort of straddle those needs, and how might this tool, or what sort of problems is this tool solving for your team?
Well, I think there's kind of a two parts there, right? So selfishly, from the Mercer perspective, we have a similar issue for Aetna. We're a large organization. We service clients, individually, but want to have kind of an equity. So if you're engaging with us on the East Coast, you have a similar experience as if you're engaging us on the West Coast. So we have the similar kind of due diligence lens. Don't want different consultants to have a different approach to evaluation. So that's one piece. But then from the employer perspective, I think it helps actually more for the V1C that might be evaluated to know what might table stakes be before I approach an employer. Because I think we sometimes, or often, employers are constantly getting kind of that outreach, because the employer at some point is the brass ring, kind of the final frontier of getting your solution out to market, and can be tricky because of the variability. And so for them to know ahead of time, like, maybe I have a really good story in effectiveness, but my integration story is lacking. To have them kind of know what they need to work on without the employer having to tell them, it is helpful. So they can kind of be best prepared to make a solid business case that's going to resonate with an employer.
Love it. Carrie, Shelley, want to chime in from your end on infrastructure, or I know so the deal making frictions is something we keep coming back to. Either one of you want to comment?
Well, as an early stage company, I was an investor most recently, and now I have joined on the operating side. And what I find is that the nomenclature, or the words that people do use, or what they care about, is very different from a health plan to a self-funded employer, for example. And while the problems might be very similar, if you're talking to a clinician, you have to have clinician speak. You have to talk about outcomes and patient demographics, and you need to be able to talk about out savings, because that savings is going to then be resonating with the medical team or the economics team. if you're talking to an employer, they might care about completely different things. They might care about retention and the flexibility of somebody in their job or their ability to not take so much time off of. So what I like about the tool here is that it does give some consistency to the common denominators that will cross all of the different employers and the various constituents.
Thank you.
Yeah,
So
I
with,
couldn't agree
oh,
more.
go ahead. Yeah.
No, I was just going to say I couldn't agree more. I think that's exactly what the tool accomplishes. The other thing I guess I would just call out is, have respect for the fact that you're working in healthcare, and healthcare is a service industry, and first and foremost, and while you're a technical solution, it's really about the service and making sure that you're being very clear about how that comes across in the course of caring for patients. That's just something that we can't underestimate the importance of.
So true. Okay, so we've been talking about the tool and how excited we are about it, and now it's time to give you a tour of what we're talking about. So let's go off of. Everybody see am I sharing the correct screen? Yeah, okay.
Yes.
Off of this one. And let's navigate over to, actually, I'll show you the overview first. So the core competencies, here are the 4 core competencies that the team has defined. So effectiveness, trustworthy digital experience, administrative efficiency, and clinical and operational integration. And it probably in this order, although again, you come to the table and think, well, is any one of these more important? If it doesn't work, then none of the other things matter. But what kind of evidence do we need? So we really approach this as these are really non-negotiable competencies. And of course, just telling you the what is not really going to be as helpful as providing as much information and insights as we can about the how-to. So we made this, actually it was Elizabeth who said, make sure that this is an interactive tool. And let me show you everyone can see the website. I invite everyone to follow along. Our team will put a link to the Impact website in the chat. I'm really proud of this because I think it really does serve up material that the Impact Consortium has been creating. So if you navigate over to resources, you can see that the Impact V1C Core Competencies is now a new tab for resources. And what I like about this tool, everyone can see, I'm going to make it a little bit bigger here, is really try to make this much like peeling the layers of an onion. So each of these core competencies is essential, but to really dig into how do you measure effectiveness? What are the success indicators? What insights can we give to either buyers or providers on how to get there? So if you navigate, you can click into these and get deeper and deeper layers of information. So we really looked first at how would you measure whether or not a solution is effective or shows effectiveness? And these are the dimensions of the success indicators that really fell out. And then you can look and see, each stakeholder will have a different perspective. So you can click through on these to get a sense. I'm not really going through the content, but really showing you that we thought very deeply about not just the what, but the how. So considerations that you would have in looking at effectiveness, for instance, and how different stakeholders, again, have slightly different priorities. And again, one thing we do very well at Dime, I think, is gather and create resources. So dig even further in to these, you can get a hold of the resources. So I wanted to highlight this one specifically because this field of really defining what effectiveness looks like and how to measure it in V1C is a emerging industry, we would say. So we have chartered a project that will launch new tools in June and early summer that really do map this. But just really briefly showing, for instance, in this, the Trustworthy Digital Experience, if you click through that, you can see how we have both a whole suite of tools that organizations can click through to learn more. So applied digital ethics course. And actually this, I got a code for everyone that you can take this course individually for a discount. Very, very useful, very practical way to understand both how to approach both the data sharing and the equitable approach to using digital medicine. So take a look at these. But I really wanted to show you that this tool is more than really just the 4 competencies, but so much goes into that. So with that, I'm going to switch back to our content page here and look at our first dimension. So now is our chance to really dive into the content a little bit more deeply. And oops, sorry about that. Shy slideshow. The blue button's very compelling. So click it. So effectiveness, this idea that it's not enough now just to, this is the walk and chew gum, not enough to have a great a technical background or maybe a scalable infrastructure or really fun app, but you also need now to show that there's scientific evidence of both clinical outcomes, economic, patients will use the platform, and all the rest. And that is a challenge for companies coming in new to the space, but it is absolute requirement. So I wanted to I'll stop sharing this here and go back to our panelists. Dr. Nelson, your role, if I read your sort of LinkedIn profile, is you're really dedicated within MWell to quality and outcomes, both the research side, but as well as ensuring that daily quality improvement and excellence within MWell. Can you talk to us about how you approach that? Why is this important? And maybe what's changing that you see in terms of expectations in the market?
Sure. So yeah, and I've worked my whole career in a focus on measuring health outcomes. And before I came to Amwell, I was within a large health system and focused on clinical outcomes as well, patient safety, quality, and population health. So it's a topic that's near and dear to my heart, and I'm excited to be able to dig in on that here at Amwell. So, when you think about clinical outcomes, there's lots of ways to measure it. A lot of times it requires a data sharing. So this sort of bridges over into the trustworthy aspect of the tool, because data sharing in and of itself is its own challenges, and a lot of negotiation may need to take place, because as a digital solution, you don't necessarily have the data yourself. You may have it, but it may require, getting some data from whoever your client is. But being able to demonstrate a whole range of impacts that are both clinical outcomes, absolutely patient safety. There is no margin for error in healthcare. And so that's just got to be like table stakes, is making sure that the safeness of the care is strongly considered. But then also, as was mentioned in the tool, patient experience, clinician experience. Clinicians have been burned by technology solutions in the past. The electronic health record is the classic example of that. And the last thing we need to do is to contribute further to clinician burnout. In fact, we need to make it a priority to mitigate the burnout. And how does our solution help with that? How does it maybe support patients between care so that, some of the care doesn't require a clinician? There's also measurement around efficiencies, right? So how do you help patients get to goal more quickly with the tool in terms of whatever their health needs are, getting to the target of improving their health? And then staff efficiency. So think about the kinds of ways that the solution can be an efficiency for the beleaguered healthcare staff. We hear so many people are leaving medical care, and it's truly a problem. And so health systems and others are forced to do more with less. And how can solutions potentially be an enabler of that? So just a few comments there in terms of how to think about the variety of outcomes you could be measuring.
Well, when I think about this, and this is my sort of challenge to you, virtual first care shouldn't necessarily be looking at anything different than traditional healthcare. So what is different? Are there new opportunities? Is the bar higher? That's the question that keeps coming to mind. Like, why do we even need to talk about this? And
yeah,
one thought, though, I was talking to Glenn Loomis from 30 Minutes. He said, we don't want to just show that we're comparable. We want to show that we can deliver outcomes over and above.
100%. I'm so
So,
glad other
yeah.
people are saying that, because that is exactly my take. I have heard folks complain that somehow, digital solutions are being held to a higher bar than brick and mortar. And I say to that, let's prove that we can deliver better than what we've seen in brick and mortar, because that's certainly no benchmark to hold ourselves to. I know firsthand over the many years of practice, the challenges that we've seen in quality and safety in traditional healthcare settings. So this is our opportunity. We have a chance to bring different solutions together and use technology to enable a better health outcome than what we might have ever seen before. And I love the challenge of holding us to that.
And you guys use the real-time data that's available so much more effectively to not just retrospectively look at quality, but continuously.
Real time.
Yeah,
exactly.
that's a huge power of the virtual space and physician space.
And I would say, I think we have a hurdle there, because I don't disagree, but Lynette, you were asking earlier about research, and we conducted a study at the end of last year with a couple thousand respondents in the US, and only 30% said that the quality of care for virtual care was as good or better as in person. So while that might not be reality, there's at least a perception that we have to overcome in adoption. And I think that we can get there, but part of that, when I connect it to the employer strategy and that we're talking about outcomes, if we borrow a writing adage, show, don't tell, well, it's measure, don't tell. So the more we can get that out there, report on it, and make it clear that the service that you're providing is superior or at least on par, I think the more we can do to kind of assuage that fear.
And when we talked during the prep call, Elizabeth, you had some data from employees that was like, we want this, and everyone really, we have data from Omada Dime survey that employers are leaning in, that we have data from Rock Health that says consumers are leaning in and really want digital care, virtual care. But there's a tension now when we sort of move into this trustworthiness that, you have some data that we talked about there, that there's a tension between sort of the trust aspect. And tell me a little bit about, I don't know if you guys want to chime in on sort of moving into the trustworthy digital experience piece.
I don't know if trust is exactly how I would categorize it.
Okay.
That's definitely part of it, right? Like, we've had some instances more in the direct-to-consumer space where that trust has been broken. And I think what really shows it is that there's kind of, I can see the future where this is going to be appealing to me. So the 65% of people were like I can see the appeal in the future kind of digital health. And only 9% were like, I don't like it. So if you're like, kind of on the like, I'm open to it, to I support it, that's most people, which is great. But if you look at how they're actually thinking they would access care, we've got a huge gap. So all the way from like, I have a simple concern, to I'm managing a chronic condition, to I have a serious diagnosis like cancer. Very, very small percentage are saying that they would access care virtually. Like, in-person care is winning by a landslide. And so if we take chronic condition management, for an example, only 11% say that they would think to use telemed as their virtual care, as their access point. So at the same time, we have that tension of like, I think it's cool and appealing, but when it comes to me using care, that's not the first thing I think of. So that's one thing. On the other hand, we have a huge concern with affordability and access, which ostensibly is the perfect thing for virtual first care, right? If you're having trouble finding an appointment at a time that works for you or fast enough, and you're worried about the cost, like that's right in our bread and butter. So I think, I don't know what the answer is there in terms of kind of education and adoption, but we're close, I think.
That is a question. I feel like, Chris, you in your role but you're working on that within Aetna as well as in CVS Health, trying to figure out how to bring patients and members what they want while also educating them about the more efficient. So I don't know how you think about sort of navigating those tensions. And there's virtual first plan design and other things coming down the pike that contemplate this. So.
Yeah, that's right. I think part of it comes down to just understanding that you can't really talk about virtual care all of the time as just this large umbrella topic, right? There are use cases where it's extremely, valuable and superior than in-person care, and brings the access, the convenience, the quality, the economics. They're all there. And then there's other use cases where, I think we're still figuring it out, right? And maybe it's not there quite yet. Right. So I think it's about starting to get real specific with use cases and scenarios on when virtual care is perhaps the better option for you, and really starting to educate and build designs around incentivizing that, not just with our members and our patients, but also with our provider partners as well, and educating them as the gatekeeper to perhaps steer somebody to a virtual option as opposed to always bringing them into the traditional setting.
I would add as well that 11% it really feels like a small number of people who are embracing virtual care. That actually surprises me that it would be that low. But having said that, 55% of all of the patients that come to us for women's health, and we at Visana, we treat women's care from menstruation to menopause and focus on the conditions that fall outside of family building. And when we are focused on them, 55% of them don't have a PCP or don't have an OBGYN or are not utilizing standard and regular care. And the reasons are broad: stigmatized conditions, embarrassing to talk about, don't have access, high deductible health plan that costs a lot, low quality, 5-month wait, 2-hour drive. I mean, the and keeps going on. But it could just be, I can't take off work. I've got a baby at home. I'm having trouble. I have to take my vacation time to go to the doctor. So all of the above works for virtual care. And we're seeing that for all of the above. And we're finding repeat users. That was so convenient. I had help getting my care coordinated. All of the reasons that we're talking about. And even if you just get 11%, that's access, affordability, and great outcomes for people who maybe aren't doing it otherwise. So I think that there's a real interest, and people are trying it. So I feel like that there's a good future for virtual first care.
Yeah.
Mhm.
And I think, go ahead.
Oh, sorry. I was just going to say, just on that 11%, I mean, put it into perspective. It's 11% now, but where was it 2-3 years ago? Right. I mean, that 11% is still
Great point.
meaningfully and significantly, by multiples
Fraction.
higher than where we were 3 years ago.
Yeah.
And I would say the other, so virtual care, we've just scratched the surface, right? So if people think of virtual care as video visits, obviously that's, the potential is far beyond that. And we need to bring tools together in a common platform in order to be able to have these tools accessible easily for them within, this single space. And that's the integration work that ultimately I think will get us to much more user uptake. Is that, it's that one stop potentially where they can go and get a whole variety of needs met.
I think you're absolutely right. When I say, when I hear, you've got a virtual first plan, first thing, well, does that mean I can't see my in-person provider? It's sort of we really don't like either or. But if it's to Shelley's point, we'll take care of you in all the ways, and we'll help coordinate things for you. That's a huge, that's a value for patients. And I think also sort of extends, as a health economist, I'm thinking, when we look at hard ROI, back to our effectiveness, looking at the economics of it, it's time to start baking in what the impact of convenience and access is, because I can't remember who it said, but it was the chief medical officer said, we're at the point now where our access issues in mainstream healthcare are a safety concern. It's not convenience. This is really about outcomes, and not and equity, so that making care accessible to people really does directly. So that's something I, thinking as an economist, how do we start to train ourselves to measure the right things that are valuable? So that we're trying to bake that into the project. Any other points on, oh, sorry, go ahead, Karen.
I was just on the topic of equity. One of the populations that has really maintained high levels of utilization of telehealth, and that I'm not hearing people talk about much, but I've seen the Medicare data on this, is people with disabilities. And I recall so distinctly in practice, I had this one couple that were, disabled. She didn't speak much English, she didn't drive, and he had a lot of, physical disabilities. And to get them to come to my office, this was, before the pandemic, before telehealth took hold, was a major event in their lives. So they had to get a ride. They had to then make sure, sometimes the ride didn't show up or it was late. They'd come to the office, get their care taken care of. And then before, they had to leave, they had to wait for their ride again. And sometimes, it was past closing time and we just leave the office open for them because they were still waiting for their ride. This was a major event in their lives and it didn't always actually go smoothly at all. And so for people with disabilities in particular, these solutions are tremendous equity enablers.
I love that. And if you're following along, sort of digging through the tool online, you'll see that, when we said, look at your outcomes and then do the subgroup analysis, understand what populations you might be either leaving out or particularly that you need to study more. Same thing with your digital platforms. In the accessibility trustworthy digital experiences, can different users use your technology? Is it required that they have a high-speed broadband? Is it required? So like thinking about digital divide is the concern, but the flip side of that is, who are you providing access to and how are you treating patients who otherwise wouldn't have? So I think we've tried to bake in that, not just allay the concerns of the digital divide, but really make sure that in all of these sections we are driving that that these solutions are great. They have to be great for everybody. So any thoughts on that, Shelley? I know you guys go way over and above when you're starting to get into the integration piece, but really connecting the dots in ways that traditional healthcare has not in the past for patients.
I think a lot of what we're trying to do is to offer a differentiated care model, the ability to be a real medical clinic and write prescriptions and diagnostics and labs, that very consistent to brick and mortar. But we also believe our care model best practices is to have these wraparound services of diet, exercise, nutrition, pelvic floor therapy, mental health support, cognitive behavioral therapy. And it doesn't fit into the usual bucket of a 15-minute visit at the doctor and then no follow-up or no touch points. And we're also, our third level of what we do that we believe is differentiated is to provide very, very strong care navigation with brick and mortar. How do we get the patient at the center of what we're doing to provide the best care? And that requires a different thought, a different care model than how we are used to treating patients historically. So being able to make appointments, work to identify high quality, low cost in network, to be able to save money, better patient access, and being able to have tools that help with consistency for identifying patients, identifying in-person, buying to support. I think a lot of the work we're doing here at Impact has consistently allowed for an expansion and a development of new models.
Mm-hmm. I love that. And I'm going to share my screen again one more time and jump over and show you the tool. Because of what Shelley said, I mean, you're a startup, you're a young company, and holding yourselves as integral to your model that you're going to focus on this clinical and operational integration, because you know that that's how you get those sustained outcomes. That's how you get that differentiated ROI. That's how you retain patients. So this is an example of a project that we did within the group last year. We looked at the clinical and operational integration from the standpoint of transitions of care. So looking at a patient journey, how well does your solution or will the solution that you're evaluating, right, Chris, be able to get patients onboarded? So all of the administrative and technical work of getting history, of pulling in data, understanding who their care partners and caregivers at home might be, figuring out, excuse me, who their other care team might be. So the value of this, let's show you this example here, for patients along the care continuum is really all of the technology stack that you have in place that enables you to do all these processes efficiently, right? So you don't have 100 manual points of integration. The ability to get patients downstream services, because we know that, you know, in gynecology is a great example. You're going to need to have devices placed. You're going to need to have tests done. How do you navigate patients to services locally when you are a national virtual clinic? And then the step further is, how do you help them find the services that are maybe in their network that are high quality? So those are like multiple double clicks past what we traditionally have seen. And that is what we are holding ourselves to, that level of excellence. And so you can actually navigate to this section of the tool, and it will take you to, if I go to learn more, it'll take you to all of the resources that this impact group created last year, case studies of how others are doing it very well, as as, you know, our thoughts on a technology stack that facilitates best in practice care transitions. So really that all bakes into, you know, what we see as those things that you need to be able to do and what that looks like. So, you know, everything from insurance eligibility and coverage. And to Chris's point, when you come with a new solution, being able to have a story, or I think it was Shelley, being able to have your story down for each of these. How are you, and even if you're a startup and you haven't figured it out yet, know that that's something you need to be able to do. And I want to come back to the trustworthy bit, because as a national clinic, don't necessarily have that presence, and you don't have a presence in the local community. You don't have the billboards. You don't have the local referral networks. And we have seen, and again, it's not just limited to virtual providers, but we've seen the sort of pressure to grow and acquire patients has led to some practices in advertising that are really, I think, eroding the trust. So I want to spend a minute on that piece, because it sort of pushes us into the operational efficiency. But how are you going to acquire patients? How are you going to do that in a way that enables you to grow without compromising legal obligations, but also trust? Anyone want to take that? Carrie's unmuted. No, it's a big question though, right? I mean, we really need to hold ourselves to that standard, and it's something that I don't know that I have a solution to, but I'm curious what you.
Yeah, I mean, honestly, there is no potential for a therapeutic relationship without trust, right? That's the basic, you know, currency in a healthcare encounter. And maybe that's why some folks aren't really going the direction of digitally enabled care, right? Is that they have that human connection with their care team that they've developed a trust relationship with. And so I think I do think that it's a big hurdle for us to be able to get to that engendering trust. And the more recent information that's been coming out around, you know, some marketing efforts that are really breaking privacy, you know, constraints. It's doubly damaging because we're already starting from behind by not having that human connection necessarily.
Mm-hmm. Mm-hmm.
I think it's, you know, in this type of scenario in the world we're living in now, it's important to have some kind of a broker for that trust, right? Whether that be, you know, a trusted brand like a CVS Health, or your partnership with a local health system, right? Yeah, that you're partnered with and providing services on behalf of, right? And I think those partnerships become really important in kind of getting traction and building trust. And, you know, kind of that brings back to this tool, right? And to get those level of partnerships, it's being able to nail the core competencies, right, that are in this tool that make it comfortable for somebody like a CVS Health or somebody like a Mount Sinai or whoever, right? To say, yeah, I'm gonna put my name behind you.
Yeah.
Right. And or your plan sponsor, your employer, to put their name, behind a group.
I also think that trust can be perhaps achieved better in some levels with a virtual first care provider. We often see patients who are homebound, maybe they have a disability. We're seeing people who were identified at some point as a female and now are identifying as a male and are really not sure where they're going for their medical care. And so there's this ability to have a screen in between you and be able to talk about conditions or things that impact your own medical care in your life that sure the heck beats going and talking to the receptionist and then the nurse and then the person and then. In addition, our care model allows for women to be seen for an hour. And in an hour, you can develop trust in a way that you can't if you go in a 15-minute appointment. And if you get the same person talking to you about all the various aspects of your medical care that's going on, you can talk about not only your concerns of your mammogram, but your hypertension and maybe your menopause and all of the various conditions, because you have an hour. You can have a full hour to where the clinician has a better perspective. And so I do think that while trust is different for everybody, I do think that virtual first can enable a much better care model for some people.
I love that. And you were reading my mind thinking about how do we segue from trust, partnerships to, well, you've got to get paid. And you mostly want to be in network or contracted with an employer or a health plan. And this model where you can spend an hour with a patient or you can chat with them asynchronously many, many times to get to the point where you have their story and you can meet their needs and they trust you. That doesn't necessarily out of the box fit into traditional contracting and payment models. And that I think that's sort of our last pillar, if you will, or our last core competency is how easily does your model fit into the existing structure, while also pushing the envelope. Like I said, these are high bars, right? And I talked to Chris about this. If you want to navigate to the sort of administrative efficiency, which sounds so cold and so easy, but we talked to Chris about, so we want you to come in with a model that is an hour with patients, it solves their needs because we can see that it works, you have evidence. How do you then broker that conversation and get started in a contract that may be, starting with fee for service? We talked a lot about flexibility, Chris. We talked a lot about, so tell us about that.
Yeah, that's right. I mean, not all contracting models are right for all provider groups or all scenarios or conditions, right? And everybody likes to just jump right to VBC. That's the big hot buzzy thing. But even within VBC, there's a whole range of models with dual-sided risk, upside, downside, pay for performance, right? So, but if you get into the wrong model, right, then it doesn't work for either party, right? Because somebody just ends up underperforming on some measure, and then it doesn't work. So I think it's really important to be flexible to say, like, let's start in model A. Maybe that's fee for service, or maybe it's a very simple pay per performance, right? Build some experience that we could then play forward into a more robust, more sophisticated model. And at the same point in time, just to revisit a point you made at the very top of the call, right, is at the end of the day, these are still provider groups, right? And there needs to be a level of just baseline sophistication that they could do what a typical provider does. They could credential their providers, they could submit claims, right? They can, share quality data, right? Especially if you're going for a VBC arrangement, right? And do so in a way that doesn't require a lot of extra overhead and hand holding and support, to get there. But that flexibility is really important, just to make sure that we're getting you into the right model where you're going to be successful and have the opportunity to grow, as opposed to just jumping right into something with a whole ton of overhead that just unintentionally squashes the group.
So true. And, for the very earliest stage companies, we had a great opportunity at Vive to talk to some investors that are very active in this space. And I said, well, how do you think about a company that's just coming with a great idea about access and the care model? How do you think about how they get paid? Like, what do they need to be able to do if they fit so clearly into value-based? Is that the best place? They say, well, no, we want to see that they have a path to payment, positioned for, but with that same flexibility, because you have to be able to start. Like you said, you have to be able to bill claims. You have to be able to track your quality. Any comments, Shelley? I know this is the idea of how much effort does it take to work with you is sort of the general theme for this. And if you look in the chat, Alyssa put a link to the contracting toolkit, which is one of a series of toolkits that Impact will be. So we're going to be now focusing on sort of more details and managed care and value-based contracting, things like that. But the contracting toolkit really lays out, as a provider, what does your contract need to look like differently or the same? What do you need to be able to do? What are the different payment models that might apply?
Well, one thing I'd love to say on that, I'd love to say that the toolkit for contracting has been extraordinarily helpful, because especially as a young company, when you're starting off, you have to develop your own processes, your own procedures, everything internally. And you don't have 25 years of experience, et cetera, of contracts to build upon. So they're all very different as well. We got one this last year that clearly was intended for someone developing things for the kitchen, their plastic forks, or the delivery of maybe manufacturing equipment. It had nothing to do with healthcare or the delivery of medical services. And yet it was the standard contract that they start with for everyone. And by using our toolkit, we were able to say, these are the must-haves from a medical clinic. These are must-haves that we cannot forget about to fulfill all of the legal requirements, but also just good business hygiene. So I feel like having some foundation to rely upon, it was really helpful as an early stage company. But I think that given some of the companies we're dealing with might be established health plans, they're self-funded employers, that might be Fortune 200 companies, this applies to them as well. So I would highly recommend people to take a peek at some of these toolkits.
Thank you. Oh, so such an excellent segue. My goal for this meeting was to both introduce everyone on the line to the toolkit and hear from our incredible panelists. Thank you all. My sort of lightning round to close us out, though, which is probably my most important goal, is to talk about how do we get this toolkit into the hands of all the right people. Like you said, the big payers that have the challenge of evaluating 100 companies coming across their desk every other week, to the startups that may be wanting to get access, market access, but want to be able to hone their narrative or even product design, to the employers who may be looking for one thing but not asking about the details of sustained outcomes, et cetera. So, who wants to go first? But tell me how you're going to use this tool in your organization and the advice you have for us to disseminate this work.
Yeah. So, I mean, I'll start. I've got some really low hanging fruit where I think this is going to be directly applicable. We're one of our lines of business is looking to go out to an RFP for some virtual services. And I think this is going to provide a great place for them to start and provide some structure to the RFP that they're putting out in the market, what they need to ask for and what they need to be sure to cover off on. And then on top of that, they could layer in, the nuanced questions for, their particular line of business that cover the regulatory needs they might need to cover, or whatever economic constraints they might need to work within, or what have you. But I think this is going to be a great starting point for them to say, look, here's the 4 buckets that you need to cover, and here's the types of questions that you need to put out in your RFP.
Love it.
Yeah, I mean, I envision using it as we evaluate partnerships. So, with the nature of our platform is such that we have the ability to partner with a variety of different digital solutions and enable that platform effect of easy prescribing from a single place. So this is a great tool for me to be able to evaluate some of those potential partnerships.
I would say that the tools available on the website for any young startup company, take advantage of it. It really did help us to be able to identify what are the key core constituents of everything from identifying patients, engagement, enrollment, economics, outcomes, contracting, handoff of patients. So it provided a very nice scaffolding for us to develop KPIs and policies, procedures around. So we've utilized a lot of it. It's been beneficial.
Elizabeth, get the last word on this.
Yeah, I think, there's again kind of the dual purpose use. It's the same thing as it's an evaluation tool. It can help us in a competitive bid situation, not only think of minimum requirements, but each client is slightly different in what they're going to index on in terms of like, well, maybe the member experience is really important to me. Like it has to be, to use a buzzword, consumer grade. So that digital experience has to be as easy as buying batteries on Amazon. For some, it's going to be the clinical outcome. So kind of sussing out where the client is going to be like most interested or most, the highest bar for them to hit. And then I think I mentioned already, like a little bit as Mercer, but our clients definitely are getting outreach all the time by a ton of point solutions, and they often send it to us and say, is it worth meeting with them? And it's very easy for us to say, send them to this checklist. I'd like you to look at it. And if you don't meet this bar, then we're not ready to meet with you. So it can act as kind of a gate or separate the wheat from the chaff a little bit to make sure they're kind of, showtime ready.
Beautiful. I love that. Thank you all. I'm going to share my screen. My team put a couple upcoming events in. So my ask to everyone on the line, well, first, thank you for joining. My ask to you is to really go back and think about how you can use this tool. Contact me if you want more details around something, or a PDF that you can use and have trouble accessing it. And then most importantly, if you are interested in joining us in creating these tools, this is the group that sits down in meetings every other week and really hashes this out together. So the Impact members are just an incredible group, and I'm so honored to be able to serve them. So that's get in contact with us if you're interested in joining that. And click throughs here. So here's my contact information. I'm pretty easy to find on the website. And want to just call out, we have in our last minute some upcoming events that you'll want to make sure that you see. So women-centric digital health measurements and monitoring. So definitely check out this webinar coming May 3rd. It'll be up on the website as well on Dime. So please check this out. And there's one more. That's it. So this is our upcoming, but we have something pretty much every other week at Dime. And I appreciate you all for listening and getting in contact with us. And thank you to the wonderful Impact members, and especially our panelists. You guys bring so much wisdom and enthusiasm to this work. So thank you.